Thank you for joining us today. My name is Cindy Holliday, and I am a member of the Board of Directors for the Movement Disorder Foundation of Arizona. And on behalf of the Movement Disorder Foundation of Arizona, I would like to welcome you to this webinar featuring a presentation by Dr. Thakkar on balance and gait issues in Parkinson's disease and movement disorder patients, followed by a question and answer period with Dr. Thakkar and Dr. Evidente, who is a medical advisor to the foundation. I will be moderating the introductory and acknowledgement section of today's presentation. First, for a bit of housekeeping for today's webinar. This webinar is being recorded, and within the next few days, the recording will be posted on our website, and a link will be provided in a follow-up email. Please understand that nothing said during this program, including the questions and answers with the doctors, is confidential. Accordingly, we ask that you not disclose any personal medical information. Any such information that is disclosed may be revealed to other attendees and individuals viewing the webinar recording. On your Zoom screen, you will notice a question and answer box at the bottom of your screen. Please submit any questions that you may have for the doctors and sponsors at any time during this webinar. You may also submit questions via email to Melissa at director@mdfa.us. All registered attendees will be receiving an exhibitor's guide after the webinar. Finally, it is my pleasure to introduce the organizations and individuals who are sponsoring today's webinar. Our first sponsor for today's webinars are Boston Scientific, represented by Lindsay McGuire.
Hi everyone, my name's Lindsay McGuire and I work for Boston Scientific. We are proud to be one of the sponsors for this event tonight with the MDFA. We're about to show you a video of a patient right here in Arizona that has the Boston Scientific Deep Brain Stimulation System. And please feel free to reach out to me if you have any specific questions about our technology.
My name is Kenneth. My name is Kenneth Brown. I'm a pastor in Fountain Hills, Arizona. Back in my 50s, I was able to walk in the Grand Canyon, hike all the way in to Phantom Ranch, and back out again, a 23-mile round trip. That became history with the onset of Parkinson's. I lost the ability to do that because my legs would tighten up and my back would begin to curl and I'd be walking bent over, and I just realized I can't do this anymore. I had to give it up, and that was very frustrating. I found out about DBS surgery as a result of a guy in town who was the editor of the newspaper who had DBS surgery. And as soon as I read about it, I said, that's what I want to do. The reason I chose Boston Scientific is because of the lifespan of the device, at least 15 years with the battery in the device. And I'd heard about people having 3 or 4 years and having to change the battery out. And I didn't want to keep getting cut open over and over again. When I first had the DBS device turned on, I experienced no tremors. Within a day or two, my toes were no longer curling. When the doctor told me that you had to recharge the device, how do you recharge something that's in your chest? The doctor pulled out a collar like this and put it around his neck and said, just like this, when you hear a triple beep, it's done. And I thought to myself, well, that's a piece of cake, I can do that.
Thank you, Lindsay. Our next sponsor is from Medtronic, represented by Jill Wallace and Joey Gregan. Jill and Joey are not able to join us for the webinar, and we have a video to share. Thank you, Jill and Joey.
I've had Parkinson's now going almost 10 years. I was a father and a husband and a career real estate guy. And I was an athlete, and then I was 47 and I got Parkinson's. I felt sorry for myself for a little bit of time, and I had anxiety over my wife's situation. You know, she didn't marry a guy with Parkinson's.
Brian talked with his doctor about DBS when Parkinson's disease began to limit his freedom.
For me, DBS has been a game changer. I look back and I remember how bad it was. It has improved my situation so much, I almost take it for granted.
DBS therapy requires brain surgery that may include serious complications such as coma, bleeding inside the brain, seizures, and infection. DBS therapy may cause worsening of some motor symptoms associated with your Parkinson's disease and may cause speech and language impairments. For more information about DBS, visit medtronic.com/dbsinfo or call 1-866-617-7246.
The next sponsor is from UCB, represented by Pat DeQuela.
Good evening, everyone. We are honored to share a few words of support with everyone participating today. My name is Patrick DeQuilla, and I work for UCB, where we are inspired by patients, driven by science, and every day one of our priorities is to improve the lives of people living with movement disorders, specifically Parkinson's disease and restless leg syndrome. UCB is proud to sponsor this event, and we'd like to thank the MDFA for the opportunity to participate in this virtual conference. Thank you for your participation, engagement, and voice.
Pat, thank you. The fourth sponsor is Neurocrine.
At UCB, everything we do starts with one simple question. How will this create value for people living with severe diseases? Our commitment to patients is embedded in our core. From how we work, to how we think, to how we hire, and from where we focus to where we invest. It is our patient value strategy. We deliver differentiated medicines that help patients achieve their goals and work to provide improved access to these solutions. We relentlessly innovate, both in how we rethink the patient journey and in our significant R&D investment to incubate new solutions. Our relationship with patients extends beyond medicines to include programs, partnerships, communities, and philanthropy that support their overall care experience. By putting patients at the heart of everything we do, we enable people to live their best lives, delivering impactful solutions patients value.
Thank you, Pat. The next sponsor is Neurocrine, represented by Aaron Yayakos. Aaron is not able to join us for the webinar. Please look in your exhibitor guide for more information on Neurocrine services offering. Aaron, thank you. Now I'd like to introduce Dr. Thakkar, who will speak on balance and gait for patients with Parkinson's disease and movement disorders. Dr. Thakkar earned his Doctor of Osteopathic Medicine degree from Western University of Health Science in Pomona, California. He completed his medical internship at Mount Sinai in New York, followed by his neurology residency at Loma Linda University Medical Center in Loma Linda, California. Dr. Thakkar then did his fellowship training in movement disorders at the University of California, Los Angeles. The primary focus of Dr. Thakkar's practice is patient-centered care for Parkinson's disease. He believes in the importance of creating a global awareness of the disease and strives to stay current with all modalities of care throughout the movement disorder field, including conditions such as dystonia, chorea, Huntington's disease, essential tremors, botulinum toxin therapy, spasticity, and other abnormal involuntary movements. Dr. Thakkar, please share your screen now.
Okay. All right, everybody. Can you guys hear me? Welcome. I'll be talking about balance related to gait and Parkinson's disease. As a movement disorder specialist, this is one of the most important aspects of Parkinson's and activities of daily living and safety as we age with Parkinson's. And as a movement disorder specialist, we try to determine how do we reduce the risk of any sort of issues with Parkinson's related balance. So I'll give you clues into what we look for as neurologists, let alone just movement disorders. Objectives today will be, again, understanding the impact of walking as a disability and what to look for. We're going to talk about appropriate medical evaluation from a neurologist perspective, and also kind of discussing the importance of physical therapy, getting workup appropriately with your primary care doctor and cardiologist. We'll understand the complexities of walking, and there's a lot of research that's gone on about how balance and gait is related to the cognition in Parkinson's disease. And we'll talk about therapies, and typically most of the therapies and discussions will be done through our question and answer towards the end. So please feel free to bring in questions as directed already. So most patients, when they come into our clinics, there's vague comments of unsteadiness, slowness, dizziness, and these are all utilized sometimes related to gait and balance. We want to understand why patients fall or feel unsteady, but the moment we start hearing about dizziness and lightheadedness, we presume there may be a combination of how the eyes and ears coordinate with our brain, how our eyes, ears, and then central nervous system affects our immediate balance of our legs and reaction times. So these are the type of things that we look for. And the dizziness that most patients with Parkinson's state when they come into our clinics is usually like a feeling of unsteady, like they're rocking on a boat. And that gives us an idea that there's an off-centered issue of their center of gravity and their balance upon standing. So these are situations that when we're looking for our answers, we want to be more specific. The questions have to be, when are we having balance issues? What is the determining factors? And that's when we ask, is it happening when you're getting in and out of a chair? Is it when you're taking quick turns? Is it through a doorway? We want to ask certain aspects of speed of walking. Are you going slow when you're having imbalance, or is it when you're walking fast? Do you notice that you're better going up steps or down steps? These are, again, situations that we do see that sometimes patients are better in different gradations. Certain surfaces are better for patients and maybe worse on others. We want to understand by family members about the length of steps that patients take, the width separated by the feet. And there's initiation factors where patients first try to get out of the chair and they may take short steps. We call it festination. And then patients may speed up where they can't control their legs. So the details of the environment are so key. Do people feel imbalanced or that dizziness when they are lying down as well? Or is it just when they stand on their 2 feet? Does it occur when they're sitting in a chair? And does that become more unsteadiness or balance in a stationary position when trying to turn? So we want to understand, is that dizziness or unbalance also when we sit? Because there may be other factors like tremors that can make us feel shaky and imbalanced even when we're sitting. Sometimes we have patients with no hand tremors, but only leg tremors. And when they're standing in one spot, their balance could be off because of the tremors that are signaled in their off state or when their meds are not working. Like I commented earlier, we've seen patients feel only imbalanced maybe when they're going up or down steps. the visual cues of the steps can also be misleading for people with Parkinson's. And we see with advancing disease of Parkinson's that this visual spatial depth perception is off, and it can make people feel like they're almost in a dizzy state or in a vertiginous state. So we always want to ask when people complain of imbalance, are you feeling lightheaded? Have you fainted? Is there weakness of certain muscles, or are you also experiencing any numbness or tingling? Unfortunately, when someone gets Parkinson's, they may also have other conditions like hypertension, diabetes, may have had a stroke or not. And such things like diabetes may also cause already some numbness, which adds to this delayed perception of the feet on the ground and different steps. And that again affects balance significantly. So we want to always understand one's medical history. Some surgeries may affect people as well. If they've had lumbar surgeries, back pain that's caused by a disc bulge, they may be chronic history of nerve damage at the back that again affects the sensory and motor symptoms or motor fibers of the legs. So again, the clinical history is so valuable for us. And for a movement disorder specialist, we really want to understand medications, especially those that lower blood pressure. With Parkinson's disease, we see a lot of abnormal, erratic blood pressures. Sometimes it's low, sometimes it's high. It can happen when someone's just sitting down and there's a lot of lability with the blood pressures. And then that happens as well with standing for patients. But we've seen in patients with taking certain Parkinson's medicines that also upon standing, the blood pressure drops significantly, which creates this gait imbalance factor. So gait disturbances, walking instability affects, we know, all aspects of life. And our concern is, can we avoid the serious injuries? Can we prevent the long-term disabilities that can lead to loss of independence? We want quality of life to be as strong as possible, as good as can be, and we want to avoid the institutional circumstances that come with consequences of falls. We also know that there's a significant burden with cost to the healthcare system based on needing helpers, nighttime caregivers, extra physical therapy, occupational therapy, and unfortunately, with these falls that can lead to bleeds in the brain or fractures and then secondary surgeries, there's higher rates of mortality. What we've seen in large population-based studies, that there's prevalence of balance issues, gait abnormalities. In patients 70 years and older, it was about 35%. And as we get older with age, 46% of patients can reported balance issues 85 and older. Now, this is again a circumstance where 50% of people 85 and older are at risk of falling because they feel unsteady. And we need to understand that with walking, especially with Parkinson's, we always think of walking as a motor task, but I want to teach upon you today that it's not just a basic reflex. It's not that we knew how to walk when we were born. We learned how to walk, and we learned how to walk slowly. And we had this development of our central nervous system, around 6 months to 9 months of age. And when we are dealing with Parkinson's, we end up having a deterioration or breakdown of these same pathways that we've learned when we were children or babies. And this aspects of these fine cortical processing centers, sensory centers, motor centers, we lose that with Parkinson's as it's progressing. So I want you to understand it's a very complex system that we have, and the aspects of walking kind of starts like a locomotion. We start off slow with Parkinson's. We may have to build up speed and then we can walk better. But what we do know with age, without Parkinson's and with Parkinson's, there is a reduction of gait velocity. Our stride length is also reduced by 20%. The characteristics of aging, as we see, is commonly aging changes our stance. So we have an increased width in how we stand. There's increased time spent in what's called double support phase, where both feet are on the ground. So when we're taking steps and trying to push off, maybe we have a reduction in the swing phase of our legs from right leg to left leg. We have also a bent posture. We've also know that there's less vigorous force with each push off, which again leads to less height of our step, and we can catch ourselves on, an uneven surface, a curb. So it's again very important to understand these characteristics. With Parkinson's, a lot of the physical therapies have been based on talking about big and loud. And one of the aspects of big is big steps, large exaggerated movements. And this is something we have to combat with the characteristics of aging and walking. So with patients who have Parkinson's and a flexed posture, their center of gravity is much more forward. And we have to be able to adjust for that when we're changing positions from sitting to standing or laying down flat to sitting up and then trying to get up from the chair or bed. The center of gravity is much more forward, and that's where we can have an instability of our legs not being able to catch up to our flexed posture. I wanted to show you some studies that have gone on for many years, and even the last 20 years there's been a better understanding of walking and balance. But one of the aspects that is important is dual task performances in patients with Parkinson's and not with Parkinson's. So in healthy subjects, which means those without Parkinson's, for instance, if you're trying to carry something, or you're carrying grocery bags in both hands and walking, maybe talking on the phone, being distracted and walking, those are dual tasks. Walking is one task, and then whatever you're doing with your hands or talking with someone is the second task. Studies have been shown that even in healthy people, that motor errors were related to the complexity of the dual task. So for instance, if someone was walking and counting backwards, we see a variability in one's walking. There's a reduction in one's speed and steppage. If someone's, for instance, being distracted with talking with someone on the phone, maybe it's dark, so we have to look at visual cues and maybe our hands are out more. Those are concerns that we have with dual tasking. So we know with healthy subjects that when they're trying to recite alphabet backwards or spell words in reverse, there is continuous evidence that the walking speed and balance and sway is variable and worse. So this is, again, with healthy subjects with dual task. When we look at patients who have dual task with memory issues, for instance, Alzheimer's or mild cognitive impairment, we see that the more severe cognitive impairment, the worse it affects balance. So here are a few studies that showed that when patients with a decline in their thinking were doing dual tasks, again, either spelling, reading something, subtracting numbers from 100, there was, again, much more variability, further reduction in speed of walking. And again, this is much more determined that the worse the memory, the worse the balance issues and higher risk of falls. And this is based on different assessments of balance and gait. So with dual task processing in Parkinson's, what we know is that patients display already a greater amount of gait asymmetry. One side's always more affected in Parkinson's based on tremor, stiffness, and slowness. That stiffness and slowness, again, asymmetric on one side more than the other. So one leg could be not stepping as properly, forcefully, quickly. And we know that there's a reduction in bilateral coordination based on the studies. We know that there's increased variability when patients with Parkinson's do dual tasks. So the more we're distracted, the more variability we see with that leg that's slower, stiffer, and less reactive. And this was compared with age-matched controls during the same dual task conditions. So typically with Parkinson's disease, we already have a reduced speed, and that affects our reaction times. So with the dual task and cognitive processing or the demands of what we're thinking about really affect patients. I see many times when my patients are walking down the hall, when I'm examining the gait and they get distracted and look into a different doorway, they start shuffling their feet. Again, goes to the aspect of just being distracted is a dual task. And we've seen this in numerous clinical studies, whether they're retrospective studies. And we go into, there's been a discussion about what's called wrong prioritization, which means you need to, when you're walking, you need to focus on walking. When you need to start talking, you stop walking, and then you have that discussion. So we want to have the priority of walking only. If you're using a cane or walker, you utilize that carefully, what is most ideal based on the physical therapy assessments, but maybe not to also use something that's too complex. So it may be certain walkers aren't as good for us, and trying to prioritize our steppage may be distracted by the holding on to the walker that's maybe not appropriate. Some walkers may be better than others. Maybe some canes may be better than others, or some walking sticks may be more appropriate. So we've seen that even if you are utilizing some aid, it has to be, you have to still prioritize and make sure that you're coordinating your legs in an appropriate fashion. Some people talk out loud and state right, left, or 1, 2. Some of our physical therapists teach our patients to say heel, toe, and that helps with, again, prioritizing each step. But we do see that patients with Parkinson's who have intact cognition, they are better in their ability to take better steps, similar to healthy adults without Parkinson's. However, as we age with Parkinson's and we see cognitive decline, it's far more difficult to take proper steps, and we see more freezing of gait. There's been studies that show that if there's a decline in verbal fluency, there's higher rates of this disability, and sometimes we see this verbal fluency tested on neuropsych testing. What further makes it complicated is if we have white matter disease, which is what you see on the left of the brain scans. When you see mild, the moderate, and severe amount of white matter disease, the white color, the bright areas, that also adds to instability of walking. These certain areas and pathways affect steppage, and we believe that there's a subtype called postural instability gait difficulty in Parkinson's, whereas others may be tremor predominant. There's a specific also affected areas of the brain that makes someone have characteristics of this PIGD subtype. When we look at the white matter decline based on injury, there's also sometimes a cognitive impairment as well. There's also atrophy in certain areas of the brain, which means a reduction of the size. And there's been data that show that those who have more freezing of gait or difficulty with dual task performances, there may be a reduction in certain areas of the brain. And as we see with the arrow pointing on the far right, the corpus callosum, there's some atrophy or reduction in size versus someone who's healthy and more of a thick, robust size. There are, again, more disturbances of gait and balance. So reaction times are sometimes slowed, and those signals that occur from the brain down the spinal cord to the legs and back up, again, those signals are delayed, which again worsens one's gait. So medical conditions that again affect balance in Parkinson's, we don't want to underestimate hyper or hypothyroidism. There's heart conditions that, again, if we have irregular heartbeats, if we have slow heartbeats that require maybe a pacemaker. We know other neurological conditions may affect patients' balance, including B12 deficiencies. If you already have had a stroke or have musculoskeletal weakness, that also affects our patients. With walking, if you have gout, make sure that's treated. If you have spinal stenosis, that can worsen one's balance with Parkinson's. And as we see bone issues, including osteoarthritis, that can be affecting our low back pain at the knees, again, will affect our balance. We know that Someone who just maybe had new medicines for an infection and they're maybe confused, that will increase the risk of imbalance, so delirium. If you're having low sodium levels, low glucose, this again adds to coordination issues. If there's been spinal cord injury, that can also affect how our balance is and our reaction time. Muscles may be more rigid and stiff, affecting our Parkinson's as well. And I don't want to underestimate vision impairment. Please check with the optometrist or ophthalmologist at least once a year to monitor for such situations of nighttime imbalance. Now, the neurological exam is very important, where when a patient comes in, we want to assess their thinking, their processing. We need to understand as well if they've had issues with their vestibular, their hearing and eye pathways. Sometimes we do see that maybe someone has vertigo, they have something called nystagmus, maybe medications are affecting their ear, eyes, coordination, and there's certain areas of the brain that can be affected by certain meds, maybe certain blood pressure medications as well. We want to be able to check that there's good blood flow from the carotid arteries that are, again, we need to have good blood flow to the brain in all aspects. And if we see low blood flow, then higher risk of falls as well. If there are heart conditions, that allows us to be very particular in making sure we do the right referrals. It's kind of like if we have back issues, we want to see the orthopedist appropriately. And these are different tests that we do as neurologists. We look for vision, we look for strength and power, make sure there's no fatigability. A lot of imbalance with Parkinson's gets worse as the day goes on. There's, again, a lot of fatigability in the legs of patients with Parkinson's. We see that posture gets worse as the day goes on. And we need to look for sensory abnormalities that may affect gait as well. There's certain tests that we do with finger to nose testing to make sure certain aspects of the brain, like the cerebellum, are intact. And we do see that that may be a sign of maybe a vitamin E deficiency. So our examination involves quite comprehensive head to toe visualization. We want to see how people are standing, whether they're with their eyes open or closed. We test their cadence, their speed walking down the hallway, sometimes even by distracting them and telling them the days of the week backwards. We want to understand steppage, how they turn, how they stop, how their arm swings. And again, we've also seen where balance is really much affected with how your hands are. So we see a lot more imbalance with hands in the pocket. Keep your hands out, swing them freely and appropriately side to side. And that allows also to improve balance where you have a better sway. We do certain tests, again, to look at the stance, swing phases, and making sure that our patients are putting pressure on their feet and pushing off accordingly. And again, we want to understand posture. Again, if we're much more flexed, we're going to have what's called festination and short steps, short, fast steps that lead us to falling. When a patient's coming into our clinic, again, we're going to look for certain blood tests. If we see some sensory abnormalities like B12, we want to get neuroimaging. And again, hopefully today you're comfortable understanding that you have to be proactive about balance and reducing risk of falls. And sometimes, you know, some doctors may be late on doing imaging of the brain. Again, ask the neurologist to maybe get an updated imaging in case there's a concern of imbalance from a fall, making sure there's no bleed or stroke. And we sometimes do certain testing on the cerebrospinal fluid, we call it CSF, in case there is a buildup of spinal fluid in the brain and the ventricles. So it's very important to be following with your cardiologist in case your heart's not pumping well. And we do certain tests again to make sure that we're stable. As we look for classifications of walking, please be mindful of when are these imbalances occurring? Is it when is it happening all the time? Is this something that is episodic, that's unpredictable? And then it cues us as neurologists and movement specialists to determine what the cause could be. So with cognition and gait, hopefully we've understood that when there is a decline in our thinking, maybe forgetful with words, maybe forgetful with fluency of how we get words out from our mouth, we do see a correlation with freezing of gait. Some patients may have a visual spatial decline in cognition, and that again may affect how they will go through doorways, different surfaces, tight spaces, maybe closets. And so executive attention is also very important in walking. This is just a brief diagram kind of understanding how the brain and different pathways are involved. We're showing here dopamine pathways in the basal ganglia, which is what we know is reduced in Parkinson's. These pathways are affected by our emotional response. If we see a fire, our heart's gonna beat fast. We're trying to get out away from the fire. It sends signals to the midbrain and it goes down to the spinal cord and sends signals to move our legs fast. Sometimes before our basal ganglia can even react voluntarily. We, again, use volitional processing to tell ourselves, pick up our feet, swing your arms big, and again, this interactions with our basal ganglia. Sensory signals, of course, from our environment may affect us significantly, especially where we see a ball being thrown at us. Maybe a person with Parkinson's who looks slow may be able to catch a ball very quickly if it's coming their direction. Our reflexes may be quite good with Parkinson's, even if we look slow. Maybe if a book is falling, we can quickly react. And then again, the cerebellum has different pathways that we see with the basal ganglia and how we get sensory feedback and make smooth, coordinated movements, whether it's with our hands or feet. And that's, again, affects balance significantly as we see as all these pathways work our way down to the spinal cord to the legs. So this is a way of looking at cognition and volitional response, where you think of something as you're processing the illicit movement. We send signals from the higher level cortical regions down to the spinal cord to the muscles, and then we're able to run quickly. And we, again, as we think about it and we do it, like again, picking up our feet, right, left, we can do this as a cognitive volitional process. So a lot of different processes go on. We know if we have strokes to certain areas of our brain, that will affect our balance as well. The frontal areas of our brain affect initiation of gaits. We know that if we affect primary motor centers or secondary motor centers, or certain planning centers of our brain, pre-planning centers, that also affects freezing of gait and getting started. So there's motor strip and sensory strip, but certain areas before we send a signal to the areas of the brain that make movement, the pre-planning areas could be reduced in size. And if there's reduction in the size of these areas, whether it's from injury, trauma, degeneration from Parkinson's or Alzheimer's, we do see that pre-planning areas affect how we take steps appropriately. So in emotional response, we call it flight or fight reactions. These are projections of areas in the brain called the limbic center and the hypothalamus that send signals and may bypass actually our basal ganglia. And sometimes with music, listening to things that are upbeat, we may be able to get better steps, better rhythm, improve our cadence, which again may help us. So if we think about something that is scary, we may have an emotional response, react a certain way, and that hyper aspect will make us fight or flight and run. So emotional responses can be uplifting, they can be shocking, but they kind of jar the system. So first and foremost, prevention, get a home health safety, be very cautious with what's around, grab bars in the bathroom, be mindful of keeping spaces open. If there's coffee tables all around that need to be maybe moved aside so you can have more of an open space, we can reduce the risk of shuffling of gait. Wear appropriate footwear, avoid sandals if you already have shuffling your feet. We want to, again, see the physical therapy upon onset of imbalance. If you feel like you're weak, fatiguing, need evaluation with assisted device, physical therapy is highly important. If there's cognitive decline, there have been studies that have shown starting certain medicines to boost alertness and cognition may help freezing of gaits. And again, it's very individualized with what medicines may work or help. There are, again, Parkinson's medicines that we have to adjust, make sure that maybe we're more continuous in our dosing, make sure we're not missing medicines, and keeping it very regular. The compliance of taking carbidopa, levodopa, or certain dopamine therapies is so important that when the medicine is wearing off, maybe we're more at risk of falling. So we want to be mindful that how the timing of our meds affects our day-to-day rotation, turning, twisting, and that's key. And again, if there is any vitamin deficiencies, nerve issues, have that corrected properly. With walking, you can do this at home, but work on your hip flexors, lifting up one leg at a time. You can do this sitting down, maybe having an extra weight. Physical therapists do a good job of working on strengthening those hip flexors. If there's anything you can do is work on your abs and hip flexors. Also, the extension of the knee is important. And, you know, the knee flexion can also be very important because it helps with pushing off. So if we can strengthen around the knee and really focus individual muscles, that really helps with balance and instability. And as we know with Parkinson's, most of the imbalance occurs one side more than the other. As we walk longer, our toes and our push-offs get weaker. So really focusing on foot flexion is another aspect of therapy. Individualizing here, as we see with bands, the plantar flexion of the foot, again, working individually one at a time, and the dorsiflexion of the toes, again, very important. So there's extension and dorsiflexion, which is important. So again, from a conclusion of understanding, see your neurologist for balance issues. Hopefully a movement disorder specialist can be of utility. If it's Parkinson's related, make sure you see regularly your cardiologist, ear, nose, and throat in case there's some ear tinnitus, hearing issues, or loss of hearing that may affect balance. Check your eyes with your appropriate ophthalmologist. And as we know, walking can affect all aspects of life. Be very candid with your neurologist about how your balance is so we can act upon it sooner than later. We need to do a thorough evaluation, follow up appropriately with physical therapy and occupational therapy. And if there's any memory issues, the caregivers need to be definitely much more aware of this, that how it can affect balance. I hope that was engaging. I'm going to stop sharing and we're going to go to a point of questions. Cindy, I don't know if you need to delegate how we're going to do the questions. Evidente is going to start with some questions.
Yeah.
Dr. Evidente, are you going to join us now?
Yes, I am.
Thank you.
That was really outstanding. Do you hear me?
Yes.
Okay, wonderful. That was really outstanding. That was really comprehensive. You know, I'm quite impressed with your discussion on the GAIT parameters. Do you actually use a Xeno map or some kinematic gait analysis software or map to analyze the gait characteristics so that you're able to really know what's wrong with our gait, or whether the gait is just because of their age and orthopedic issues?
Yeah, so there's different therapies that I used to use. There used to be a GAIT lab I used to work with very closely, and unfortunately with COVID, they've had to close down. So there are certain GAIT labs that exist that are focused on such details of sway, positional, postural. A lot of our physical therapists utilize certain machines as well, and they give analysis based on timing, based on pressure, maps of the feet. I get some clues and tips from that. I usually depend on the physical therapist to work on those details. And right now with practice, we haven't been able to utilize as much of those GAIT analysis, but it is quite helpful, especially when we start a medicine or even, as you know, Dr. Evidente, with deep brain stimulation, how that may affect balance. In case we're worsening balance, we want to know what programs or stimulation parameters help.
And with patients that have undergone DBS, are you impressed with any differences between STM versus GPI for balance or freezing of gait?
You know, both can be beneficial based on certain situations. So I was trained at UCLA, which is a very big center on DBS, but they were very pro GPI, globus pallidus, which is an area for our audience that is much more away from the midline centers, away from the spinal canal and signals, whereas the subthalamic nucleus is a lot closer and medial of a structure. So if there was sometimes signals that are to the globus pallidus that we send, there's less potential side effects with over-signaling and overstimulation, whereas with the subthalamic nucleus, maybe we would get too much stimulation to help control a tremor, that maybe we would affect parameters of speech or balance. Now, the key thing is if someone's very stiff or rigid, you know, deep brain stimulation does a wonderful job, whether it's STN or GPI, to reduce that stiffness. And we can actually program in certain ways where speed can be improved. And so there are some times where we overstimulate one side, maybe like the right brain, to control the left foot very carefully by signaling it much more. And how we signal it, maybe a certain amount of voltage with a very low frequency. And there's other parameters, as we know, to maybe lower the pulse width, which is, again, a certain type of signal that's not too intrusive.
Okay, we have some questions from the audience. The first question is, I am surprised to hear only 35% number for GAIT survey. And was the morbidity increase only due to secondary events?
Yeah, and again, these are data that was done by, I think, the American Academy of Family Practitioners, but the mortality rates are, again, usually secondary measures, again, from a complications of fall that included bleeds, surgical complications, but again, related to hospitalizations from Parkinson's phenomenon.
And then a follow-up question to that is, please expand a bit more on CSF tests and what measures.
Yeah, so we do MRIs to look at the structures of the brain, but also there's certain cavities that we see called the ventricles of the brain. And those ventricles, certain areas can be actually enlarged. And as they enlarge, they put pressure on the white matter of the brain as well as the gray matter, and it pushes the brain centers really against each other. So if we think about a room that we're in and we're blowing up a balloon and blowing it up and blowing it up and blowing it up, it will cause, you know, space surrounding to be pushed against the walls. So same thing goes with the ventricles. If they're enlarged, it can cause some irritation to the brain centers for walking and balance and even thinking. And there's a mimicker of Parkinson's called normal pressure hydrocephalus, which again will affect balance, thinking, and even urinary control. So sometimes we do what's called a lumbar puncture to measure the pressure of the cerebrospinal fluid. And if it's elevated, it may be suggestive cause of normal pressure hydrocephalus to a certain degree, even though we say normal pressure, it should come out, but we see patients sometimes walk better right after taking out extra cerebrospinal fluid, and they may require something called a VP shunt if that's the case.
Yeah, and I'm quite impressed over the 2 decades I've been in practice, or probably more, of the coexistence of both Parkinson's disease and NPH. And in fact, I've counted maybe at least a dozen cases in my practice now. And so whenever I see patients with prominent lower body Parkinsonism, they're wide-based, they have gait ataxia, their feet are not together, they're not really shuffling, they're more ataxic more than anything else. Mm-hmm. And even balance is a very prominent issue from the get-go. And that's when I kind of suspect, especially as you mentioned, they start having some urinary urgency, and then later on incontinence, and even later on some cognitive issues. That's when I start suspecting that maybe NPH might be in play. I also suspect NPH when a patient is referred to me for Parkinson's, as mainly lower body Parkinsonism, no tremors, put on levodopa, and absolutely no response to levodopa, and their main concern is balance and falls. So I guess my follow-up question to you is, how frequently do you ask for brain MRIs in your patients that are referred to you for Parkinson's?
I would probably say that we also do CT scans as well, and if there's been specific concerns of newly diagnosed Parkinson's or something like normal pressure hydrocephalus, I typically would go to some more detailed MRI. Predominance is most patients would have some imaging already done. If not, I would like to at least get some baseline imaging. I would like to make sure that even if they have Parkinson's that looks like it's idiopathic, coming about as a slow progressive disease, as a majority case area, I want to make sure there's no mimickers of Parkinson's, like a stroke, a bleed. We see these situations where, in very rare situations, but they do occur, and we don't want to miss something that could be maybe treated, or it gives us an idea as to understanding why medicines are working or not working. I don't typically get a DAT scan necessarily, but I do focus on getting some form of imaging at least once at the beginning of a diagnosis. And then if there's major changes in walking or balance or numerous falls, I want to make sure there's not a bleed that has curtailed or occurred.
Yeah. Okay. Another question from the audience. What do you mean about blood pressure can fluctuate with Parkinson's? Can that be controlled, or is that the new normal?
Wow. I mean, I'm sure most movement disorder specialists are now, they should get a second degree in being a cardiologist, because we focus so much on blood pressure. In Parkinson's, we see such erratic highs and lows. I mean, a patient could be sitting and I can check the blood pressure, and it can go it can be 110/70, and it can shoot up to 170/60 without, much time being passed, and they're just still sitting there. I've had patients who are sitting down and they're 160/40, and then they stand up and it drops to 70/30. There's such erratic drops of blood pressure and also erratic highs of blood pressure, and there's some system that's not working that is checks and balances to the highs and lows of these erratic blood pressure. So we as neurologists utilize some medicines to make sure the blood pressures don't drop too much. We have therapies that are there to keep blood pressure at a certain level, and we have to be cautious that the blood pressures don't go too high. But most of the time we reduce some patients' blood pressure pills that they're already on that controls their hypertension, so we can try to avoid the bottoming out.
Yeah, and there have been studies that have shown that even in the so-called pre-motor stage of Parkinson's, for synucleinopathies like Parkinson's disease or multiple system atrophy or dementia with Lewy bodies, that if you were to do formal autonomic testing, many of these patients actually have some autonomic abnormalities, and orthostatic hypotension, which is what you just described very eloquently, which is a drop in blood pressure from lying to standing, and the cutoff usually is about 20 millimeters mercury of the systolic blood pressure. Many of our patients actually, even in the early stages of a Parkinson's syndrome, or even the premotor stage, may have some form of autonomic neuropathy. It can predispose them to these orthostatic symptoms. But again, I think many patients also are asymptomatic. Like, I'm really impressed at how many of my patients with high blood pressure, with Parkinson's, and then we take their orthostatic blood pressure. So we're not sure whether it's a blood pressure pill that's doing that or the underlying autonomic neuropathy. They have 30 or 40 point drops in their blood pressures, and yet they're not dizzy at all. Yeah. So I guess a follow-up question to you is, do you treat automatically these drops in blood pressure, or do you wait till they're symptomatic, or what do you do?
Yeah, that's a very good question. So again, I'm talking to Foundation of Arizona. So you guys, as well as California, we deal with droughts, right? We deal with heat waves. So one of the biggest drops and causes for low blood pressure or autonomics is lack of hydration or dehydration, and that's something that if we're seeing drops of more than 10 millimeters mercury with the systolic top blood pressure, I definitely even start, educating about how to be either liberal with salt, maybe adjusting medications. Even if they're asymptomatic, I always want to make sure I'm asking about, are you feeling dizzy, or asking about this unsteadiness. Sometimes patients may, bring it out once you kind of really are asking such situations of like, when you bend over to pick up something, and when you get up, do you feel kind of woozy? Like in those circumstances, I will, just be mindful of not necessarily medicines, but just, good habits. I typically would only start treating if they're becoming more symptomatic, or if I'm seeing that there are falls unexplained, then we typically go after that if there's objective measures.
Well, yeah, absolutely. I echo that 100%. And especially here in Arizona, where we have dry heat, and many patients actually get dehydrated. They think they're drinking enough fluids when in fact they're actually perspiring the fluid, all the fluids away, and therefore they get dehydrated despite taking the so-called recommended amounts of fluid. So I guess the first aid measure, or the first thing I ask them first is, how much fluids do you drink? And also I try to make them, add some salt if the fluid hydration is not sufficient. Now, what about B12 deficiency? You mentioned in your talk the importance of the relationship of B12 deficiency and gait abnormalities. Do you feel like this is something we should be measuring routinely in our Parkinson's patients?
Yeah, one of the things that we learned is in training, in neurology training specifically, was a test where you have a patient stand, and we call it the Rombergs for those who aren't aware of it, but it's you stand and then you close your eyes and then you see if there's an imbalance. That's one of the tests that if someone is unsteady significantly when they close their eyes, then I will definitely look for a B12 deficiency, and that's one of the hallmarks of it. If someone tells me, when I ask on the exam their social history, if they have any special diets and they say they're vegetarian, I typically would check for B12 deficiency. And anyone who comes in with for the consultation that says, hey, I'm having balance issues, I will check for B12 and other types of associated minerals like homocysteine and methylmalonic acid. And there's certain tests that we would do to look for that. But I wouldn't say I would do it every single patient. But one thing is that we do see, even like vitamin D. Vitamin D is there's a lot of vitamin D deficiency out there. And I see that much more in the general population and even our Parkinson's patients, but that may not affect balance as much as something like B12. Actually, today of all days in the morning, I found someone who had a B12 that was extremely low, and her main complaint was memory issues and balance. So can't wait to see how she responds with high dosing B12. Typically, we could do injections or ask them to take sublingual supplements, but that is something that is quite important in addressing.
Yeah, a couple of important points that you mentioned that resonate to me pretty loudly. The first is you mentioned methylmalonic acid and homocysteine. So I think the take-home message is that a normalish or low normal B12 can actually not be normal, and that one of the things that Dr. Thakkar mentioned is taking the methylmalonic acid and homocysteine levels, which increase when you're not absorbing the B12 and the B12 is not making it to your tissue. So if we really strongly suspect, especially if you have a neuropathy, you're falling, you have imbalance, you have numbness of your feet, and so on and so forth, you have some cognitive issues, then despite the so-called normal B12, I usually push for the methylmalonic acid and homocysteine levels to be measured. And homocysteine is elevated homocysteine levels have also been noted very frequently in Parkinson's patients without any B12 deficiency, because the metabolism of levodopa to dopamine depletes B12, and so or should I say, leads to increased homocysteine rather, leads to increased homocysteine levels. So one way to bring down that homocysteine is to give these patients B complex, including B6, B12, folic acid. And then another question from our audience: can you have Parkinson's and begin to exhibit some of the early signs and symptoms without a positive DAT scan? What do you think, Dr. Thakkar?
Sorry, the positive DAT scan, without a positive DAT scan and early symptoms.
You have Parkinson's disease.
Yes, yeah. I mean, look, I typically go with my clinical assessment much more than the DAT scan. If the DAT scan is positive, then it's 99%. Yes, it's a Parkinsonism. But if it says negative, it could be incorrect 12% of the time, maybe a little bit less than that at time. But there's data that says it can be as incorrect with what we call a false negative for Parkinson's. And if the clinical suggestion is there with tremor, stiffness, slowness in a certain pattern, it doesn't mean that you have to right away treat, but you may follow up a patient for, again, after a month or two and just kind of see how they're progressing and see if their symptoms are still very similar to what you first saw. And, you really want to trust what you've been trained on. And like Dr. Evidente, you've had so many years of seeing a patient, you look at these other cues that not just a scan. We look at, is there a history of constipation? Is there sleep disturbances that are talking, yelling, or acting out dreams? Are there circumstances of reduced sense of smell, and even loss of smell, less likely than less of taste, and then so again, constipation. We talked about loss of smell, the REM sleep disturbances, and I also look for like muscle cramps. Muscle cramps are one of those Charlie horses, are one of those pre-phenomena that I see a lot as well with Parkinson's. So I really trust my skill set of that. However, we've had some unique ability to either give a patient a medicine of levodopa, whether we crush it right then and there in the office. And I've actually used, Dr. Evidente, Inbrija, which is an inhaled form of levodopa, to get an assessment of, does the patient respond, whether it's with handwriting or fine dexterity or tremors, does that go away within 15 or 20 minutes after, while they're sitting in my office? And that kind of also gives me a clue more so than just worrying about a scan.
Yeah. Very well said. I just want to add that I like Dr. Thakkar, I've seen patients that I really strongly suspect have idiopathic Parkinson's disease that's levodopa responsive. He just alluded to using the inhalational form of levodopa to test a levodopa response. Although with the caveat that it's the duration of response, the enduring response of levodopa is a stronger predictor of Parkinson's disease than the immediate, one dose or testing levodopa for a few weeks. So the pathology studies, especially the more recent ones, have shown that even among patients that are levodopa responsive, in a movement disorder center, for instance, where Parkinson's disease is very frequently diagnosed, supposedly by very experienced specialists, movement disorder specialists and neurologists that see Parkinson's every day, the rate of misdiagnosis can be as much as 42%, and sometimes even larger within the first 5 years. So really the enduring response to levodopa, and they throw out a random number of about 5 years. So enduring response to levodopa of about 5 years with motor fluctuations, meaning on and offs, which usually develop anyway on an average 4 or 5 years from from the start of levodopa treatment, as well as the so-called dyskinesias. So the enduring response, motor fluctuation dyskinesias, most likely in a Parkinsonian patient will most likely represent Parkinson's. But I've also seen patients with DAT scans that have been misread, especially those that have asymmetric findings, so very subtle findings. Not every DAT scan is the same, or should I say not every DAT scanner is the same. There are some DAT scanners that are better than others. Also, there is a special software called NeuroQuant. So you can interpret DAT scans two ways. One is qualitatively and just looking at the images and saying, okay, the dopamine signal seems to be equal in both sides of the basal ganglia, or is it reduced in one side? Is it reduced in the caudate or the putamen or both, and so on and so forth? That's qualitative. And then the quantitative, through a special software called NeuroQuant, actually measures the amount of dopamine signal in comparison to normal individuals. So I trust more the DAT scans with NeuroQuant data. But even so, the so-called normal DAT scans, if I really suspect that they truly have Parkinson's, and especially if I do a levodopa challenge, as you mentioned, I read the DAT scans myself, and I kind of say, okay, there's some asymmetry here. I think it's mildly reduced. And so I follow these patients like I see they have Parkinson's disease. And then they've also looked at these patients, they've taken a second look or even third look at these patients that initially had normal DAT scans. So there was a study, or even more than one study that's been published, where they took a second look at these patients, doing another DAT scan maybe 1 or 2 or more years after. And true enough, a good percentage of these patients that were initially thought to be normal, but were thought to be clinically compatible with Parkinson's, converted to abnormal DAT scans. So the lesson is, if your doctor really feels that you have Parkinson's, you act like a duck, you walk like a duck, you quack like a duck, it must be a duck, regardless of whether the DAT scan is abnormal or not. Okay, some more questions here. I'm going to skip the question of REM behavior disorders, since I'm going to tackle that in the questions that were asked by the audience in the second part. Here's a question. Is there any relationship between essential tremor and foot neuropathy?
With essential tremor and foot neuropathy?
Are you aware of any?
I mean, there's different types of when I see certain dystonias, I actually see more neuropathy than essential tremor per se. But if there's a good amount of Parkinson's related tremor, then I would see more neuropathy as well, but not necessarily. I don't see specifically an essential tremor relationship typically with neuropathy.
I agree. Now there's a type of tremor called neuropathic tremor. So patients with bad neuropathy, CIDP, for instance, or one of these bad motor neuropathies with atrophy of muscles. Some of these patients can develop so-called neuropathic tremor, which looks like a crossbreed between essential tremor and a cerebellar tremor. Now, neuropathy can also occur in Parkinson's patients, obviously, and I think studies have shown that the chronic intake of levodopa can actually predispose to neuropathy, and this goes back to what Dr. Thakkar eloquently said in his talk about B12 deficiency, but they've also looked at folic acid deficiency in this population of patients, also B6 deficiency. Mm-hmm. Okay. Levodopa, how much can be used safely, and what causes it to be ineffective? What is the next step after levodopa?
Well, the dosing is not necessarily what we can hang our hat on. Some people can barely tolerate half tablets 3 times a day, and some people require over 2,000 milligrams a day. So, each person is very individualized based on their response on blood pressure, if they can tolerate it as far as nausea. But, what I've seen, and with more continuous like therapy of levodopa, I see a better smoothness of their physical symptoms, including walking. And I've seen some freezing of gait improve in such select patients. Again, anecdotally, this is under, in my clinic, we have a lot of patients who've done something called the Duopa pump, and it's a continuous levodopa, which has allowed for a better stream of flow. And some people do better with less destination and less short steps. They're more on. So whatever we do as neurologists, we want to optimize the on time. We want to have patients get a good response with levodopa, but maybe some patients get a good on with also some dopamine agonists, some boosters to levodopa that are medicines called MAO-B inhibitors or COMT inhibitors. So there are medicines that sustain or lengthen the effectiveness of levodopa. And there are also maybe medications that cognitively slow you down. I mean, some patients take a lot of sleep medications, and we try to avoid medicines that are downers or muscle relaxants that slow our brain down. So there are medicines that actually make us have less on time because they are negative to our alertness and focus. So again, those are type of things that we must look at, not just a quantitative number of levodopa. We look at what other medicines patients are taking. But I've seen, even in situations where, historically people have said deep brain stimulation doesn't help gait, but there are times actually it can be quite useful. And again, it's more about what aspects of gait are affected, which is, again, if the stiffness is slowing down someone's balance, and like say the right leg doesn't just take good steps, you can with DBS reduce some of that tension and muscle tightness that allows a patient to have more free steppage. So again, that's one of the perspectives I have seen.
Yeah, and I echo that as well. And I think you do this routine yourself. We do on-off testing before DBS, give them the maximum doses of medicines that they take, or if I feel that they're underdosed, I give them a heftier dose in my office, a levodopa challenge, and then see whether their balance or gait will improve. Whereas literature will say that DBS is not meant to improve gait or balance. The truth of the matter is any motor off symptom that improves in the on state and is only present in the off state will most likely improve with DBS. So for instance, I've seen patients with imbalance only in the off state, and that improves with DBS. Or for instance, I've seen patients with freezing of gait only in the off state. The moment they're fully on with their levodopa, the freezing completely disappears. And those are the patients that do very well with DBS. Okay, we're gonna take a little break. I'm gonna pass the floor back to Cindy. She's gonna introduce the rest of our sponsors, then we'll go back to the questions and answers.
Now I'd like to introduce our next group of sponsors for today's webinar. The first sponsor is from Kiowa Kirin, represented by Paul Hollywood. Thank you, Paul. Our next sponsor is from Adamas, represented by Jeremy Killian. Thank you, Jeremy. Our next sponsor is from Accordia, and the representative is Steve Mihawk.
Thanks, Cindy. I wanted to take a quick moment and introduce Inbrija, which is the only levodopa that's available in an inhaled form, particularly for off periods. 2 capsules, one at a time, is actually inserted into the chamber. You click on it, you take a little bit of water to eliminate or reduce cough. You gently inhale. You do that twice with 2 capsules, and then as soon as 10 minutes, it starts relieving your symptoms, peaks at 30 minutes, and then it lasts out over to an hour. If that sounds like something that might help you with your off periods, whether it's in the morning, taking a long time to get going, or whether you're out on the golf course, or maybe your grandkids are there and they're wondering how soon grandma's going to make some cookies for them, this is something that might help you turn on when you need to. It can be used up to 5 times per day. And as far as side effects, the most common one is cough. Anything else that's associated with levodopa is common. So I would recommend, if it sounds good to you, ask your physician for some samples, find out some more about some of the potential side effects, and give it a try. You can also learn more at inbrija.com, and there's quite a few videos on there that will give you some more information if you want to learn more before you talk to your doctor. That's it. Everyone have a fantastic weekend, and thanks for giving me a moment to share some information on Inbrija.
Steve, thank you. The final sponsor is from AbbVie. Marjorie, our representative is Marjorie Crenshaw.
Thank you, Cindy. I'm going to go ahead and share my screen. Good evening, everyone. My name is Marjorie Crenshaw with AbbVie, the makers of Duopa. Duopa is a prescription medicine used for the treatment of motor fluctuations in patients with advancing Parkinson's disease. Duopa contains two medicines, carbidopa and levodopa. AbbVie is very happy to support the Movement Disorder Foundation of Arizona and their mission to help those impacted by Parkinson's disease. As Parkinson's advances, you may notice that levodopa pills aren't working as well as they used to. You may need to take more pills or take them more often. Parkinson's can slow your stomach, delaying the absorption of levodopa, which may impact your response to the medication. Duopa offers 16 hours of continuous levodopa delivery, bypassing the stomach, delivering levodopa directly into your intestines where it is mainly absorbed. If you would like to learn more about the risks and benefits of Duopa and how Duopa can give you less off time and more on time without troublesome dyskinesias in your day, please visit duopa.com for additional information and to hear from real patients and care partners who can share their journey with Duopa. And remember, only you and your doctor can decide if Duopa is right for you. Thank you so much for your time this evening, everyone.
Marjorie, thank you. Now I would like to introduce Dr. Evidente. Dr. Evidente is the current director of the Movement Disorder Center of Arizona in Scottsdale. Dr. Evidente is a fellow of the American Academy of Neurology and a member of the Movement Disorder Society. He is a frequent presenter and invited lecturer at national and international conferences and symposia. Dr. Evidente has also served as principal investigator and co-investigator for numerous clinical trials regarding treatments for Parkinson's disease and other movement disorders. Dr. Evidente will now be joining Dr. Thakkar and will respond to and discuss the questions that have been submitted for today's webinar. Dr. Evidente, please take it forward.
Okay, thank you. Okay, can you guys see my slides?
Yes.
Yes, we can.
Okay, very good. Okay, so the second part of the webinar is something new, and I think it's going to be fun. We actually did a little bit of it with Dr. Thakkar in the first half of this webinar, and so many of you have submitted questions to us before this webinar, which we will try to address one by one if we could. And one of the more common questions that I found very interesting, which was submitted by more than a couple of individuals since the last webinar, was about mannitol. So what about mannitol and its potential use for Parkinson's? So I prepared a few slides for on this topic. So mannitol is a supplement. It's actually a sweetener. And it is poorly absorbed in the intestines, and therefore it doesn't raise your sugar as much as regular sugar. Now, it also is a diuretic, an osmotic diuretic. So it attracts both water and salt. And this is excreted now mainly through your kidneys, and therefore this is actually being used therapeutically for patients, for instance, in the ICU with brain swelling from trauma or from a bleed in their brains, and so on and so forth. It's also being used to protect your kidneys during heart or vascular surgeries. So the impetus for the interest in mannitol started in 2013 when there was this basic scientist that showed that if you introduce mannitol into a test tube where there are toxic clumps of alpha-synuclein, and for those of you that have attended the previous webinars, we talked about this protein called alpha-synuclein, which clumps, which misfolds, which aggregates in patients with Parkinson's disease and multiple system atrophy and dementia with Lewy bodies, so-called synucleinopathies. And it is this misfolded protein that causes cells to die. And it is alpha-synuclein, the misfolded alpha-synuclein, that is the ingredient of that pathological hallmark of Parkinson's called the Lewy body. So anyway, back to this Israeli study, what they found was if you introduce mannitol into a test tube with toxic clumps of alpha-synuclein, what happens is that the alpha-synuclein aggregation gets reduced or gets reversed. And so the misfolded alpha-synuclein binds to the mannitol, and they think that the way this works is that it signals now the inherent mechanisms that get rid of this misfolded proteins in your body, in your tissues, in your cells. It then signals it for disposal. So in animal models of Parkinson's where they introduced mannitol, they found that there was improvement of the so-called Parkinsonism of these animals. And so this led then an Israeli individual with Parkinson's to take mannitol long-term for several months, and he noted improvements. So he was trying to drum up interest for research to be funded for mannitol for Parkinson's, except that nobody was interested. Why? Because it's cheap. You can buy this in the grocery store. If you live in the US, you can buy this easily on Amazon. So therefore, there was really no financial interest for any company to invest gazillions of dollars for a drug that anybody can buy, from the grocery store at a very cheap price. And so, in lieu of this, he promoted its use online and encouraged Parkinson's patients to report their clinical experience over several months in a platform called ClinicCrowd. And what they found was, and there were like more than 1,500 patients that participated in this. And of those, about 78 patients took it for more than 6 months. And what they found was that there was a 56% improvement, not only of their motor performance, but also some of their non-motor symptoms. And so this has led to a phase 2 randomized control study in Jerusalem in a center called the Hadassah Medical Center. And this is an ongoing study, which I believe will finish in 2022. It's a small study. The funding wasn't really that large. It's actually funded by the Israeli government. And they're randomizing patients to either mannitol or dextrose, and they'll find out long-term whether one group of patients is better than the other. Now, given that this is readily available and that you can buy this even in Amazon, should you be taking it? Is it safe to take it, first of all? Well, the answer is yes, at the low doses that they recommend for use for general health, especially among diabetics. It is actually present in many of the processed food that you buy from the grocery store. So without you even knowing, you may be actually consuming mannitol as we speak in the things that you just buy from the grocery store. Now, are there natural sources of mannitol? And the answer is yes. Cauliflower, for instance, has 3 grams of mannitol per 100 grams of cauliflower. Now, be careful, though, of the side effects, because if you overdo this, it is not an innocuous supplement. First of all, it can cause headaches, nausea, vomiting, dizziness, dehydration, low blood pressures, palpitations of fast heartbeats, rash, hives, and frequent urination. And then if you really get overzealous and lose track of just how much you're consuming, and you happen to consume more than 20 grams on a regular basis, on a daily basis, then this can lead to bad things. It can act like a laxative. It can lead to kidney failure, can lead to heart failure, and electrolyte imbalance. So just be careful when you use a drug of this sort that's readily available and sort of self-manage your Parkinson's. Okay, so again, one of the more frequently submitted questions was this thing on REM behavior disorder, which is in layman's terms, dream acting. So REM refers to rapid eye movement. So this is the deepest stage of sleep. This is a stage of sleep when you dream. Now, our creator was so good and so wise that he created an inherent mechanism so that you don't act out your dreams, you don't fall out of bed, you don't jump out of bed, you don't sleepwalk, you don't get a concussion, and so on and so forth. So there's an inherent mechanism built in your body where your muscles are paralyzed during REM. So this is called REM paralysis. Now, what happens though in Parkinson's is that, and also sometimes in elderly individuals, or sometimes when you take certain medications like antidepressants, that REM sleep paralysis becomes inefficient. So now you start moving and thrashing around and talking and yelling. I've had patients that dream walk. I have patients that fall out of bed. I have a patient that actually, walk all the way to the front door and started seeing, people in front of the front door, started yelling at them, go back to his room, then go back to bed, and so on and so forth. So this is not an innocuous thing. If obviously it predisposes you to injury, given that this usually occurs during sleep and at night. So they found out that REM behavior disorder is actually a precursor to a synucleinopathy. So I alluded a while ago to the so-called synucleinopathies. For those of you that want to get a review of what the synucleinopathies are all about, check out the MDFA website. About 2 webinars ago, I think this was in June, we talked about synucleinopathies and about alpha-synuclein and about the approach in terms of research of tackling alpha-synuclein, trying to reduce the alpha-synuclein burden. So if you have REM behavior disorder, they found out that this is the #1 non-motor symptom that predisposes to Parkinson's, MSA, or dementia with Lewy bodies. So what is the rate of conversion? So roughly, the rate of conversion is 6% per year, cumulative. So for instance, if you develop a REM behavior disorder at age 50, so by age 51, you have now a 6% chance of developing one of these synucleinopathies. In 2 years, you have a 12% chance, and so on and so forth. In 5 years, you have a 30% chance. In 10 years, about 60%. In 12 years, about 75%. And 15 years and above, a 90% conversion or more. Now mind you, this numbers vary depending on which studies you read. But the bottom line is that REM behavior disorder, especially that which is proven through sleep studies, because many patients talk about, I kind of observe my spouse or my bed partner talking and yelling at night. But the question is that dream acting occurring during rapid eye movement sleep? So many of us can also be talking in light sleep or lighter stages of sleep, and that doesn't count. The so-called slow stage sleep, that doesn't count. What really counts and what really predicts a synucleinopathy is the dream acting that occurs during the deepest stage of sleep called REM. And mind you, REM doesn't occur in the first couple of hours or first hour or two after falling asleep. This usually occurs towards the tail end. It's the second half of your sleep, which is why many of our patients that have dream acting tend to do that towards the second half of their sleep. And then a follow-up question that many have submitted is, are there drugs to treat REM behavior disorder? And the answer is the most common one that we prescribe. One is a supplement called melatonin. And melatonin is a substance that you produce in your brain. It is actually the the substance that powers your internal clock. Which is why when you travel from one time zone to another, like for instance, you travel from here to Europe or here to Asia or Asia to the United States and so on and so forth, where night is now day and day is now night. And you kind of have to take a little bit of melatonin to reset that internal clock. Okay, so Parkinson's patients tend to produce less of this melatonin as they get older, and that predisposes them to REM behavior disorder. So if I don't get the RBD controlled with the maximal doses of melatonin, so I usually start with 1 milligram, then go to 3 milligrams, then 6 and 9, and then maybe 10. 12 milligrams is probably the highest I would go. I've had some patients that go up to 15 and say that it's actually helped, whereas the lower dose did not. But once the maximal dose of melatonin has been used, and they're still doing the dream acting, then I move to a drug called clonazepam. I really am not a fan of clonazepam. It's a controlled substance. It's a pain in the butt to prescribe nowadays in the U.S. since you have to do this electronically now. You have to go through certain hoops, especially in Arizona. This has to be monitored and so on and so forth. And so it's really a pain. And obviously, it also causes some side effects. So imbalance in the middle of the night or falls seem to be higher if you take clonazepam. If you're demented, it probably will make your dementia worse, causes confusion in the middle of the night, and so on and so forth. Okay, and then the next question that that more than a couple of you have submitted, is there a way to prevent REM behavior disorder or premotor Parkinson's from progressing to full-blown Parkinson's disease, MSA, or dementia with Lewy body? So again, the so-called premotor stage of Parkinson's usually spans about anywhere from maybe 5 to 10 to maybe even 20 years. So this starts with poor sense of smell, the REM behavior disorder, the constipation, the anxiety, the depression, the poor sleep quality, mood changes, sweating issues, frequency of urination. These are non-motor symptoms. So is there a way, once you know that you have RBD and you have poor sense of smell, and the more of these non-motor symptoms that you have, the higher the chances you're now in the premotor stage of synucleinopathy. Is there a way to stop that from progressing further? And currently, there really is none. Although if alpha-synuclein is in the heart of the causation of this synucleinopathy, this so-called misfolded alpha-synuclein, I wouldn't be surprised if research in the future will move towards that direction of recruiting patients in the premotor stage of a synucleinopathy. Now, whereas currently we have the DAT scan to kind of confirm that you really have, the motor stage of Parkinson's, and that you really have a dopamine deficiency. Is there a way to measure your alpha-synuclein? Is there such a thing called a synuclein scan, similar to a DAT scan? And the answer is currently there's none. Although the Michael J. Fox Foundation has actually put out a call for research in the tune of several millions of dollars to groups that will come up with a way to develop an alpha-synuclein scan. Now, it will be very similar to your DAT scan or very similar to your MRI scan. You go to a radiology place, they do a scan, and the tracer that they'll use for the scan will measure the alpha-synuclein, not only in your brain, hopefully, but all over your body. Because remember what we mentioned in the webinars, 2 webinars ago about alpha-synuclein, is that this actually starts in the periphery. So the question is, can we measure the alpha-synuclein in the periphery even before it reaches the brain? And hopefully in the future, yes, with this so-called synuclein scan. Now, is there another way, given that the synuclein scan is not, alpha-synuclein scan is not yet available, Is there another way to look for alpha-synuclein? And again, we tackled this 2 webinars ago. So you can actually do a skin biopsy. You can actually do a colonic biopsy. You can do salivary gland biopsies. And I think the one that has the greatest consistency in terms of yield and the highest, the least invasive and the highest percentage of being positive or not, or the lowest rate of false negative would be the skin biopsy. So it's a very simple office procedure. It takes 5 to 10 minutes. We do a punch biopsy behind your neck, around your knee and around the ankle. And then the first lab to actually do this commercially that can be charged to your insurance is actually existing, and it actually is here in our own state, in Arizona, in Phoenix. So the lab is called C&D, or Cutaneous Neurodiagnostics. So after about a couple of weeks or maybe 3 weeks at most, they send us a report saying yes, there is alpha-synuclein, misfolded alpha-synuclein in 1, 2, or 3 of the biopsy sites. Versus nope, we didn't see alpha-synuclein, and therefore chances are patient does not suffer from a synucleinopathy. Although the rate of false negatives with the skin biopsy is somewhere around 10%. So there's still a 10% chance that even if it's negative, that you still may be suffering from a synucleinopathy. Now, are there false positives though? It's really hard to quantify the false positives, but the general feeling and thinking is that the false positives are really, really low, and that the so-called false positives that don't have any symptoms actually represent the so-called pre-motor or preclinical, or there's several terms for this, pre-symptomatic or prodromal Parkinson's, MSA, or dementia with Lewy bodies. Okay, hey, Dr. Thakkar, you have any thoughts about what I've said so far?
No, I totally agree. I mean, I probably would say, you know, one of my biggest things is, as I tell patients, that Parkinson's, unfortunately, is a 24-hour disease, and we really have to address the sleep patterns. And, you know, it's very valuable to tackle the need for maybe a sleep study. Don't underestimate that. If there's a mild sleep apnea, it needs to be maybe even addressed as if it was serious, because we know that, you know, the patterns of sleep and the oxygenation and blowing off the CO2 that's toxic can really have long-term consequences. So, but I'm a big believer of managing the REM sleep disturbances with melatonin. You know, some sleep doctors I work with utilize very, very low dose gabapentin, and, you know, try to avoid, as you stated so eloquently about the clonazepam, that, you know, we try not to utilize those as much as possible.
Yeah, I kind of noticed that most of my sleep colleagues are quick to prescribe clonazepam even before they prescribe melatonin, when in fact I get good success in a good percentage of my patients with the proper dose of melatonin. Okay, so next question. I have been diagnosed with either premotor Parkinson's or multiple system atrophy. Here are my questions. Number 1, what is the difference between the two? Okay, hey, Dr. Thakkar, you want to chime in on this one? Parkinson's versus MSA?
Yeah, one of the biggest things is the way you look at MSA is that it's a faster atypical version of Parkinson's. We think of regular idiopathic Parkinson's as a typical slow progressive over decades where one may have deterioration, but multiple systems atrophy has this variant of a faster decline in balance, speech, autonomic instability, where patients may have more REM sleep disturbances, blood pressures fluctuating. They may actually have spinocerebellar signs and cortical signs where the toe is sticking up actually. And so we have this decline that may not be quite responsive to levodopa therapy like we would get in regular Parkinson's disease.
Yeah, and then there's really very few ways one can differentiate Parkinson's from MSA. Usually it's long-term. Levodopa responsiveness can be seen in MSA patients, but it's usually not enduring. And in fact, in the autopsy studies where they found that the rate of misdiagnosis is 42% among patients diagnosed with Parkinson's within the first 5 years. The two top differentials that mimic Parkinson's that were thought to be Parkinson's are number 1, MSA, multiple system atrophy, and number 2, progressive supranuclear palsy, which is PSP. And PSP patients usually have tons and tons of imbalance even from the get-go. Whenever I see patients that have imbalance and falls as the initial symptom, I usually think of PSP first and then maybe MSA second. And then the other thing that Dr. Thakkar mentioned is the autonomic symptoms. So if you were to do an autonomic questionnaire, I usually do that almost routinely now among my patients that present with Parkinsonism, especially those with falls, especially those that present with dizziness. So patients with MSA have very prominent autonomic symptoms. Parkinson's also can, but usually if you're looking at untreated Parkinson's and untreated MSA, these MSA patients, even without being treated, are already in trouble because they already have orthostatic dizziness, drops in blood pressure, some urinary frequency, maybe some mild incontinence, especially if their bladder is full, maybe some irritable bowel syndrome as kind of symptoms, and so on and so forth. And then when you do a DAT scan, whereas in Parkinson's, a huge percentage of these patients, I'd say more than 95% of these patients, if not even more, will have an abnormal DAT scan. In MSA patients, DAT scan can be either normal or abnormal. So a normal DAT scan in a Parkinsonian patient favors MSA, especially if they have autonomic symptoms very prominent in the beginning, and favors less this diagnosis of Parkinson's. Okay. Besides exercise and hydration, is there anything else I can do to slow the progression? I think you're on the right track. Exercise and hydration are really the key. And one more thing that Dr. Thakkar alluded to: good sleep. So he does recommend, he does send patients for sleep studies and so on and so forth to make sure that you get good sleep. I think if you do vigorous exercise, so it's not just a little leisurely walk to the mailbox or walking the dog at a very leisurely place. No, it has to be aerobic. They found it has to be aerobic, it has to be vigorous, and it has to be sustained. So it has to increase your blood pressure and heart rate by at least 20 points. And if you do that at least 20 minutes every day, that's probably good exercise. If you can do more than that, then well and good. Okay, another recommendation is to make sure I have lots of electrolytes. Does this impact the kidneys? I found a supplement that you put in water called Ultima Replenishment. Any thoughts on this versus Gatorade or similar? I wasn't familiar with Ultima Replenishment. I actually checked it out when I received this question, and it's simply just a combination of the essential minerals and stevia, which is a natural sweetener, which is plant-based. So it looks like it's a good electrolyte balance, non-sugar hydration thing. But I don't think there's any studies that show that one of these brands or types of electrolyte water or fluid hydration is better than the others. Do you have any thoughts on that, Dr. Thakkar? Do you agree?
Yeah, I totally agree. There's not really much specific evidence about it on those, but again, keeping inflammation low with certain types of sugars, I think those are the key things. We always try to say keep minerals high, appropriate minerals high, and again, I think you alluded to earlier about salt, and we want to really have the ability to rehydrate, but also the muscles to relax after a vigorous exercise. So these are key things where some degree that we may need some protein, but be mindful that how it may interact with levodopa too.
Absolutely, yeah. Okay, and then is there anything in my diet I can minimize or add to in order to slow the progress? So I would refer you again to an MDFA webinar, which you can find in the MDFA Facebook page. This was 2 webinars ago on diet. And so I also gave a talk maybe a couple of years ago, and I found I found 2 slides which talked about diet and alpha-synuclein levels. But again, these are just conjectural, recommendations. There's not really hard science to back up, these things. Most of these things are based on basic research, but not in actual human studies. But they think that consuming, high levels of flavonoids, which means vegetables, fruits, berries, nuts, peppers, beans, a little bit of red wine, black tea, not too much of the wine. And again, many of my patients ask me, what's not too much? What is a mild to moderate amount of wine or alcohol? And so a recent paper I read mentions about 4 or 5 ounces of alcohol for women per day, and then double that for men would be the limit in terms of consumption of any alcoholic beverage. And then they feel that they think that the flavonoids are neuroprotective. They actually are very powerful antioxidants. And not only do they help modify the alpha-synuclein levels and prevent the clumping and the aggregation and the misfolding of the alpha-synuclein, they think that there's a lower incidence of dementia in these patients as well. Now, mind you, in dementia, the protein that, especially in Alzheimer's or even in non-Alzheimer's dementia, like PSP, the protein that misfolds is called tau. And they think that that many patients, especially those that are exposed to environmental toxins or to pollutants or highly polluted, living in highly polluted cities, can be more prone to misfolding of multiple proteins that lead to neurodegenerative disorders. It was a very intriguing study that I read very recently. So alpha-synuclein is one of them. So it may predispose you to Parkinson's, MSA, dementia with Lewy bodies, and then there's tau, misfolding of tau, that predisposes you to Alzheimer's disease. And then there's another protein called TDP43, which is again a protein that we see in another neurodegenerative disorder called Lou Gehrig's disease or ALS. So they think that some of these patients, and they actually looked at some individuals who live in this very polluted areas and they donated their brains to science. They found out that those that live in polluted areas have more of these misfolded proteins, even those that have no symptoms. In other words, they're still too young to develop a symptoms of a neurodegenerative disorder. And then they actually did there was a little study that I found on this flavonoid, which is found in a Chinese herb called bakelin. And they found that it actually inhibits the aggregation, the clumping of the alpha-synuclein. Again, that gives you, basic science evidence that maybe truly, despite the absence of good human clinical studies, that maybe what I eat can modify the alpha-synuclein levels in my body. So the next question is, can what you eat influence misfolding of the gut alpha-synuclein? So why are we interested in the gut alpha-synuclein? Because as we had mentioned previously, the accumulation of misfolded alpha-synuclein starts in the periphery. It doesn't start in the brain. In the so-called preclinical premotor stage, which is anywhere from 5 to 20 years before you develop the first motor symptom of Parkinson's, the misfolded alpha-synuclein has actually started to accumulate in the periphery, in your skin, and also in your gut. And so, and this can be influenced by what you eat. And so, what food items, experimentally, what food items have been shown to cause misfolding of alpha-synuclein, and therefore theoretically can cause accumulation of alpha-synuclein, misfolded alpha-synuclein in your gut. So these are processed food, pesticides, especially fresh fruits and vegetables. I guess even if your fruits or vegetables look clean, and they were supposed to be pre-cleaned when you purchase them in the grocery store, I would recommend that you really wash them well and good, and get rid of every particle of potential pesticide that was utilized to make sure that they don't get pest ridden. And then excessive sugars, preservatives, polyglycerol, lecithin, and heavy metals in your water. The number one heavy metal that seems to be associated, at least in experimental studies, of causing misfolding of alpha-synuclein is manganese. And in fact, we've seen Parkinsonism among miners that mine manganese. It's called manganism. In fact, a manganese exposure can lead to acute Parkinsonism or can lead to long-term changes through alpha-synuclein that eventually lead to Parkinson's. So this is one of the heavy metals that unfortunately is in your water, especially if you drink well water. And this is the main concern about whenever Dr. Thakkar and myself asked you, did you live in a farm when you were growing up? Did you drink well water, and so on and so forth? We're actually interested in this, the manganese content in your drinking water. And then the altered gut flora. So also fosters misfolding. So there's normal, healthy bacteria in your gut, and that bacteria is supposed to assist with digestion. And what happens in Parkinson's, because of this alpha-synuclein that misfolds and accumulates in the nerves, the autonomic nerves around the walls of your intestines, all the way, or your gut, all the way from your throat to your esophagus, to your stomach, and all the way down to your rectum. What happens is that the contractility of the muscles around the GI tract becomes inefficient, and therefore there is now accumulation of bad gut flora and reduction in the good flora. And this accumulation of bad bacteria in your gut fosters misfolding of alpha-synuclein. So that's one of the things that they theorize can be associated with increased incidence of Parkinson's down the road. Okay, any thoughts, Dr. Thakkar? Okay, I think we might have a time for one or two more slides. So is there a link between diabetes and Parkinson's? The answer is yes. There's an increased risk of Parkinson's with type 2, not type 1 diabetes. In fact, there's a 30% increased chance of developing Parkinson's if you have type 2 diabetes. So type 2 has to do with insulin resistance, not so much with a reduction in production of insulin. It's you produce the insulin, but your cells are not able to utilize this. So insulin is important for glucose to be utilized to cross from outside of your cells in the blood vessels and cross over to the cells where they're utilized for energy. So you need insulin for that. So type 2 diabetes patients tend to be more predisposed not only to Parkinson's but also to Alzheimer's disease. And that also leads to another question about exenatide. So we talked about exenatide in the previous webinar. This is a GLP-1 agonist. It's a drug that's being used for type 2 diabetes. GLP-1 receptors are found in the pancreas. So if you stimulate these receptors, you release insulin. And they found out that this same type of receptor is present in your brain. So there was a phase 2 study in 2017, and they used this drug called exenatide, which is actually being used in many patients all over the world, including Asia and Europe and the United States, obviously. So it's a drug that's readily available. So there was a study in 2017 in 62 PD patients, and they administered a dose of 2 milligrams subcutaneous weekly versus placebo, and they found out that the motor scores improve with exenatide. So what they think exenatide is doing is that it is, I'm not sure whether I have that slide over here, but what they think that it's doing is that it is reducing the aggregation or dissolving the aggregated or misfolded alpha-synuclein. So in fact, it is reducing the amount of misfolded bad protein or bad alpha-synuclein. And currently there is a phase 3 study that's ongoing in the United States. Unfortunately, because of COVID, the recruitment has slowed down somewhat. And so the original target of 2 years duration of the study will probably be longer. Although I wouldn't recommend that you just, twist the arm of your doctor to prescribe you this, but If you have diabetes, though, I don't, and you have type 2 diabetes, I don't see any reason why you shouldn't talk to your doctor to take to switch to exenatide. And in fact, they found out that patients with diabetes that are prescribed exenatide and other GLP-1 agonists for their diabetes. And if you compare those with patients with diabetes that were prescribed, metformin and other drugs that are not influencing the GLP-1 receptor, those that were prescribed this GLP-1 agonist develop Parkinson's much less frequently than those that were prescribed some other medication for Parkinson's. So that goes back to this mechanism of action of possibly dissolving or getting rid of this aggregated, accumulated alpha-synuclein in your tissues, whether it be in the periphery or in the brain.
And Dr. Evidente, I got kicked off a little bit earlier, but I got back on when you commented on don't twist the arm of your doctor. And I think that's very important just to state, because we have seen some patients come into our clinic to ask about this.
Exactly.
And cautiously, you cautiously need to, number one, only if you have diabetes should you actually be on such medications, and follow really closely with your endocrinologist if you have diabetes. But we have actually had some patients who tried to get on exenatide and they had very severe side effects of GI, bloating, diarrhea. Yeah. So again, I agree with you significantly and wholeheartedly that the data still needs to be understood.
Absolutely. So wait for the clinical studies to get finished before you jump on the bandwagon and want to be put on this drug, despite the fact that you know that it's within your reach, it's out in the market, it's FDA approved. All you need is that doctor to play along with this desire of yours to be put in a drug that so far is promising in animal studies and is promising in earlier phase 2 studies. But mind you, many phase 2 studies that were promising never bore out and were never replicated in terms of efficacy with phase 3 studies. We really need those phase 3 studies to show us that these drugs are truly efficacious when given to a large number of patients. Number 2, that they are safe. Okay, I think we are out of time at this point. I'd like to thank everyone for tuning in. I'd like to thank Dr. Thakkar for being such a great speaker and a great sport, and for sparring with me in this questions and answers format. We encourage you to submit more questions between now and the next webinar that we hopefully will be able to answer as well. And so at this point, I'm going to turn over the platform again to Cindy.
Our next webinar will be held on Friday, February 12th, 2021. We will send out information for joining via email next month. Thank you, Dr. Evidente and Dr. Thakkar, for sharing your expertise and experience with movement disorders and Parkinson's disease. To conclude today's webinar, I would like to acknowledge and thank all of our sponsors: Boston Scientific, Medtronic, UCB, Neurocrine, Kiowa Kirin, Adamas, Accorda, and AbbVie. Dr. Evidente mentioned our previous webinars. You can visit our website and click on the resource tab to view our previous webinars. Finally, I invite you to assist us in continuously improving the quality of these webinars going forward by answering a short survey, which you will receive via email. Your response to the content and format of our webinars helps all of us and is greatly appreciated. Thank you all and have a great evening and morning. Goodbye.